Welcome to The Truth About Low Back Pain, a clinician's guide to pain science. Low back pain is one of the most important clinical challenges allied health professionals face today. It's the single leading cause of years lived with disability worldwide, affecting an estimated 628 million people globally. The total chronic pain economic burden exceeds $722 billion annually in the United States alone. Despite those staggering numbers, there's a real and clinically significant gap between what contemporary pain science tells us and what happens in routine clinical practice. That gap carries real consequences for patient outcomes, healthcare utilization, and recovery trajectories. For decades, the clinical approach to low back pain has been dominated by a biomedical model that puts structural pathology front and center as the primary explanation for a patient's pain. That framework, while intuitive, doesn't account for the neurobiological complexity of chronic pain, the remarkably high prevalence of imaging abnormalities in people who have no symptoms at all, or the powerful influence of psychosocial factors on pain persistence and disability. Contemporary pain neuroscience has reshaped our understanding of why pain persists, how the nervous system adapts when nociceptive input continues, and what clinicians can do to interrupt the shift from acute injury to chronic suffering. Pain science literacy isn't optional for allied health professionals anymore. It's foundational to delivering evidence-based, patient-centered care. This course provides physical therapists, occupational therapists, nurses, and allied health professionals with a thorough, evidence-based framework for understanding and managing low back pain through the lens of modern pain neuroscience. We'll start by establishing the epidemiological scope and economic impact of the problem, then trace the natural history of low back pain, including the now recognized variability in recovery trajectories and the substantially revised estimates of acute-to-chronic transition rates. From there, we'll systematically explore the neurobiological mechanisms underlying chronic pain, from peripheral sensitization and central sensitization to the emerging concept of nociplastic pain, before examining neuroplastic brain changes, the disconnect between structural imaging findings and clinical symptoms, and the nocebo effects of diagnostic labeling. We'll also address psychosocial risk factors, red flag screening, and validated risk stratification tools, and we'll wrap up with the evidence base for pain neuroscience education and effective clinical communication strategies. 4 integrated case studies bring these concepts to life in realistic clinical scenarios, spanning the spectrum of low back pain presentations. All content is grounded in research published between 2022 and 2026, so you're getting the most current evidence available to guide your practice. Upon completion of this course, the learner will be able to, first, describe the global prevalence and economic burden of low back pain. Second, explain the natural history of low back pain, including recovery and recurrence patterns. Third, define nociceptive, neuropathic, and nociplastic pain mechanisms in chronic low back pain. Fourth, identify key neuroplastic brain changes associated with chronic low back pain. Fifth, recognize the prevalence of structural imaging findings in asymptomatic adults. Sixth, list psychosocial risk factors and red flag indicators used in low back pain risk stratification. And seventh, state evidence-based principles for delivering pain neuroscience education. Let's begin with Module 1, which looks at the scope of the low back pain problem from both an epidemiological and economic perspective. Low back pain remains the most prevalent musculoskeletal condition worldwide and the leading cause of disability across all age groups. The most widely cited estimates place the global point prevalence, that is, the proportion of the population affected at any given time, at approximately 12% of the adult population, with a lifetime prevalence of approximately 40%. The Global Burden of Disease Study, 2021, reported an age-standardized global prevalence rate, adjusted to account for differences in population age structure across regions and time periods, corresponding to approximately 619 million individuals affected in 2020. By 2021, the absolute number of prevalent cases had risen to 628.8 million, reflecting a 62.6% increase from 386.7 million in 1990. That dramatic rise in absolute burden is driven primarily by population growth and demographic aging rather than an increase in individual risk. the age-standardized prevalence rate actually declined by 10.4% between 1990 and 2020, which tells us the rising absolute burden reflects demographic shifts, not worsening population-level risk. Sex differences in low back pain prevalence are substantial and consistent across global populations. Age-standardized rates are significantly higher among women than men, with females affected at roughly 1.7 times the rate of males across all regions studied. Peak prevalence occurs in the 50 to 54 age group, while the peak disability burden shows up among adults aged 80 to 84 years, reflecting the compounding effects of aging on both pain frequency and functional impact. Regional variation is just as pronounced. Central Europe, Eastern Europe, and Central Asia show the highest age-standardized prevalence rates, roughly double those of the lowest prevalence regions, while Southeast Asia, East Asia, and Oceania report the lowest rates globally. Projections from the Global Burden of Disease 2021 analyses estimate that 843 million people worldwide will have low back pain by 2050. That's a figure that demands urgent attention from healthcare systems globally. Within the United States, approximately 39% of adults aged 18 years and older report experiencing low back pain in the preceding 3 months, with women reporting higher rates at 40.6% compared to 37.2% in men. The American Academy of Family Physicians cites an annual prevalence of 11% to 38% for acute low back pain and a lifetime prevalence of 40%, while the Department of Veterans Affairs Clinical Practice Guideline reports a lifetime prevalence as high as 84%. Regional disparities within the United States are also worth noting. The Midwest region demonstrates the highest mean incidence, prevalence, and disability-adjusted life years, particularly among females aged 25 to 49 years, and uninsured status is positively correlated with both higher prevalence and greater disability burden. Let's turn to incidence, trends, and risk factors. In 2021, there were approximately 266.9 million new incident cases of low back pain worldwide, translating to an estimated 8 to 10 million new cases annually among U.S. adults. Incidence rates are consistently higher in women and peak in middle-aged adults between 40 and 60 years of age. The working-age population aged 15 to 64 years has experienced a 52.66% increase in prevalent cases since 1990, reaching 452.8 million globally, a trend with serious implications for workplace productivity and disability systems worldwide. Projections indicate that global incident cases will exceed 300 million annually by 2035. The 3 principal modifiable risk factors for low back pain are occupational ergonomic exposures, high body mass index, and smoking. Occupational factors remain the largest single contributor, accounting for approximately 22% of global years lived with disability due to low back pain in 2020, with the highest attributable risk among younger males at 34.3% of years lived with disability in those aged 15 to 49. However, the relative impact of occupational exposures has declined over the past 3 decades, particularly in high socio-demographic index regions, a composite measure of development status based on income, education, and fertility rates, reflecting shifts in the global economy away from manual labor. Here's what's particularly striking. There's been a marked increase in the contribution of high body mass index, which now accounts for 14.2% of low back pain-related disability-adjusted life years, a composite measure combining years of life lost to premature death with years lived with disability in postmenopausal women. That surpasses both occupational and smoking-related risks in this subgroup. Smoking contributes to 7% to 12.5% of low back pain years lived with disability globally, with the highest risk in middle-aged males, although its impact has declined in parallel with global reductions in smoking prevalence. Additional lifestyle risk factors recently quantified in large cohort studies include prolonged sedentary time, which contributes to an estimated 12.6% of incident low back pain, unhealthy sleep patterns contributing to 5% to 7%, and insufficient physical activity contributing approximately 3.6%. These findings are consistent with emerging evidence linking overall lifestyle health scores to low back pain risk, suggesting that multifactorial lifestyle modification may offer meaningful primary prevention benefits. Several high-risk subpopulations have been more precisely characterized in the recent literature, Postmenopausal women carry a disease burden nearly twice that of age-matched men, attributed to estrogen decline, osteoporosis, and accelerated disc degeneration. Additional high-risk groups include younger male manual workers in low- and middle-income countries, Black adults in the United States who experience both higher incidence and prevalence of chronic low back pain, and females aged 25 to 49 in the U.S. Midwest. The COVID-19 pandemic also left its mark on low back pain burden. A large observational study documented that chronic low back pain patients reported worsening symptoms during lockdowns, with the likelihood of high disability associated with anxiety and depression increasing meaningfully from the pre-pandemic period to the pandemic period, while the protective effect of regular exercise of 4 or more hours per week was even more pronounced during lockdown periods. Low back pain is the leading cause of years lived with disability, or YLDs, both globally and in the United States, and it's held that position consistently across successive global burden of disease cycles. In 2021, low back pain accounted for approximately 70.2 million YLDs worldwide, though estimates vary considerably due to methodological differences across regions and data sources, surpassing depressive disorders at 56.3 million YLDs and headache disorders at 48 million YLDs to rank as the single highest-ranking condition in terms of non-fatal health loss. This isn't confined to any single region. Low back pain ranks among the top 3 causes of years lived with disability in every global burden of disease superregion, though its relative contribution to total disability varies with the local burden of communicable diseases and other competing conditions. The most recent global burden of disease analyses confirm that while the age-standardized YLD rate has declined modestly over the past 3 decades, the absolute burden continues to rise due to population growth and aging. Within the United States, low back pain has remained the leading Level 3 cause of age-standardized YLDs from 1990 through 2021, although the U.S. rate declined by approximately 7.9% over this period. Forecasting analyses project that low back pain will retain this position through at least 2050, with only a 1.2% projected decrease in the age-standardized rate from 2022 to 2050. These projections highlight the critical need for clinicians across all disciplines to adopt evidence-based, multimodal management strategies that address the biological, psychological, and social dimensions of this condition, rather than relying on biomedical approaches alone. The economic burden of low back pain is immense, covering both substantial direct medical costs and even larger indirect costs related to lost productivity and work disability. Understanding the size and distribution of these costs matters for clinicians advocating for evidence-based resource allocation and guideline-concordant care. Direct medical expenditures for low back pain span outpatient care, diagnostic imaging, pharmacologic treatment, interventional procedures, and surgery. Outpatient care makes up the largest proportion of direct costs for chronic low back pain, and the cost trajectory accelerates with each additional intervention. A claims-based analysis of 16,917 patients with non-surgical chronic low back pain found that mean annual back pain-related costs were $7,112 in the first year and $11,989 in the second year, with cumulative 5-year costs averaging $31,459 per patient. Management patterns have a huge influence on cost. The cost trajectory escalates sharply when care deviates from clinical practice guidelines. Early magnetic resonance imaging is associated with a 13-fold increase in the likelihood of surgery, greater opioid use, and 1.45 times higher acute care costs, $8,082 versus $5,560 for patients managed without early imaging. The clinical implications of early imaging are discussed further in Module 5. Pharmacologic management patterns contribute meaningfully to the overall cost burden. Despite clinical practice guidelines recommending nonsteroidal anti-inflammatory drugs, or NSAIDs, as first-line pharmacotherapy, opioid prescribing has historically been widespread in the management of low back pain. Recent data, however, show encouraging trends. In U.S. emergency departments, opioid administration for low back pain decreased from 35% in 2016 to 24.5% in 2022, and opioid prescriptions at discharge fell from 32.5% to 13.5% over the same period. These reductions suggest that guideline-concordant prescribing practices are gradually gaining traction, though significant room for improvement remains. Interventional procedures and surgery represent another major cost driver. The overuse of interventional procedures for low back pain, including facet joint injections, neurotomy procedures, and spinal fusion surgery, has been extensively documented. Medicare data document nearly 1 million lumbar or sacral facet injections and over 400,000 neurotomy procedures annually in the United States alone. Spinal fusion surgery, while performed in only a minority of patients, costs between $60,000 and $110,000 per procedure, with national annual expenditures exceeding $16 billion. More than 50% of patients who underwent spinal fusion reported no improvement or felt worse after surgery, raising fundamental questions about the value of these procedures when clear surgical indications are absent. Surgical patients account for a disproportionate share of total costs relative to their numbers, a pattern that highlights the downstream economic consequences of potentially inappropriate surgical intervention. Indirect costs consistently exceed direct medical expenditures, accounting for approximately 2/3 of the total economic burden of low back pain. The dominant indirect cost driver is lost productivity. An estimated 15.4% of the U.S. workforce with chronic low back pain loses an average of 10.5 workdays per year, equivalent to approximately 264 million lost workdays annually. Presenteeism, reduced productivity while at work due to pain, may exceed absenteeism in its total economic impact, as workers with chronic low back pain often remain on the job but at substantially reduced capacity. The American College of Occupational and Environmental Medicine estimates that musculoskeletal disorders account for 40% to 50% of all work-related health costs and 50% of all absences lasting more than 3 days. The cost distribution is also notably concentrated. Fewer than 5% of patients with a low back pain episode account for approximately 75% of total costs. That pattern reflects the disproportionate resource consumption associated with the transition from acute to chronic high-impact pain. The most thorough recent estimate of the total annual economic burden of chronic pain in the United States comes from a 2025 analysis of Medical Expenditure Panel survey data by Guy and colleagues, which places the total cost at $722.8 billion in 2021, comprising $530.6 billion in direct medical costs and $192.2 billion in lost work productivity. Individuals with chronic pain incurred $8,068 in additional annual medical expenditures and $2,923 in additional lost productivity per person compared to those without chronic pain. The Department of Veterans Affairs estimates $134.5 billion in direct spending for low back pain and neck pain combined, making it the highest spending condition among 154 conditions analyzed. The American Academy of Family Physicians reports $87.6 billion annually for back pain alone, ranking third after diabetes and cardiovascular disease. At the global level, the total economic burden of musculoskeletal disorders was estimated at $2.1 trillion in 2021 international dollars, adjusted for purchasing power parity, representing 1.41% of global gross domestic product, with low back pain accounting for the highest value of lost welfare relative to GDP at 43%. The distribution of costs is highly skewed. High-impact chronic low back pain patients generate disproportionate expenditures, with annual per-person healthcare costs more than double those of patients with low-impact pain. This concentration of economic burden among a relatively small proportion of patients highlights the critical importance of early identification and targeted intervention for individuals at greatest risk of developing chronic high-impact pain. Module 2 looks at the natural history of low back pain, including recovery trajectories, recurrence patterns, and the critically important transition from acute to chronic pain. Our understanding of low back pain's natural history has shifted fundamentally in recent years. Rather than viewing low back pain as a series of isolated, unrelated episodes, contemporary evidence shows it's a long-lasting condition with a variable course defined by recurrence and fluctuation. This has important clinical implications because it redirects our focus from treating discrete acute events to managing a condition defined by its episodic and often unpredictable nature. 3 principal pain trajectory subgroups have been identified in the literature: a recovery trajectory where pain improves rapidly or gradually toward minimal or no pain, an ongoing trajectory with moderate or fluctuating pain that persists over time, and a persistent trajectory with constant severe pain and minimal improvement. Understanding which trajectory a patient is likely to follow directly affects prognostic communication, treatment planning, and how we allocate clinical resources. These trajectory subgroups also highlight the inherent heterogeneity in low back pain. Patients who appear clinically similar at initial presentation may follow markedly different courses, making early identification of trajectory predictive factors an important clinical priority. In community-based inception cohorts, the prognosis of acute low back pain is generally favorable. A prospective community inception cohort study, a study that enrolls patients at the point when a condition first develops and follows them forward in time, found a median duration of approximately 5 days for an acute episode, with a cumulative probability of recovery of 70% before 1 week, 86.1% before 3 weeks, 90.9% before 6 weeks, and 93.5% before 12 weeks. These data line up with findings from a thorough systematic review and meta-analysis of the clinical course of low back pain, which confirmed that mean pain scores on a 0 to 100 visual analog scale decreased substantially in the weeks following onset, with acute presentations showing rapid improvement during the first 6 weeks, followed by continued but more gradual improvement through 52 weeks. Together, these findings support the clinical message that most acute episodes resolve substantially within 6 to 12 weeks with appropriate conservative management, and they give us a solid evidence base for reassurance during initial patient encounters. However, the favorable average trajectory masks considerable variation among individual patients. Trajectory analyses of patients presenting with acute low back pain in primary care have identified multiple distinct clusters, including rapid recovery within 2 weeks, gradual recovery by 12 weeks, incomplete recovery, fluctuating pain, and persistent high pain. Community-based cohort studies following patients over 12 months similarly identify mixed patterns. Approximately 54% of patients experience mild to moderate fluctuating pain, 33% have persistent moderate pain, and smaller proportions show delayed recovery or moderate to severe fluctuating courses. Identifying these trajectory subgroups has practical implications for clinical triage, as it tells us that a meaningful minority of patients with acute low back pain won't follow the expected favorable course and may benefit from earlier, more intensive intervention. Chronic low back pain, defined as pain persisting beyond 12 weeks, follows a markedly different clinical course. The most recent systematic review and meta-analysis found that persistent low back pain cohorts had mean pain scores of 56 at baseline, 48 at 6 weeks, 43 at 26 weeks, and 40 at 52 weeks, a total reduction of only 16 points over 1 year. That's minimal meaningful improvement over time, and a clinical trajectory that's strikingly different from what we see in acute presentations. The certainty of evidence for these persistent pain trajectories is rated as very low, reflecting the methodological challenges inherent in long-term observational studies of chronic pain populations. The proportional distribution of trajectory subgroups differs substantially between acute and chronic populations. Only approximately 30% of patients with chronic low back pain follow a recovery trajectory, compared to approximately 70% in acute presentations. An estimated 40% to 50% of chronic low back pain patients exhibit an ongoing moderate or fluctuating pain trajectory, and 20% to 30% experience persistent severe pain. These proportions carry important clinical implications. Once pain has become chronic, full resolution becomes the exception rather than the rule, and the majority of patients will continue to experience clinically significant symptoms at 1 year or beyond. Patients who present with a pain duration of less than 3 months demonstrate clinically important improvements across all outcomes at 6 and 12 months, whereas those with pain lasting 12 months or more generally fail to achieve clinically relevant functional improvements. That duration-dependent gradient in treatment response highlights the urgency of early, effective intervention to prevent the consolidation of chronic pain states. Recurrence is a defining characteristic of low back pain and an essential component of accurate prognostic counseling. Estimates of 1-year recurrence rates vary considerably depending on the population studied and how recurrence is defined. Conservative estimates from systematic review data suggest that approximately one-third of individuals who recover from an episode of low back pain will experience a recurrence within 12 months. But prospective inception cohort studies using more inclusive definitions of recurrence have reported substantially higher rates, with some cohorts documenting recurrence in up to two-thirds of recovered patients, including activity-limiting episodes that prompted healthcare visits. These findings emphasize how important it is to communicate to patients that while acute episodes typically resolve favorably, recurrence should be anticipated and planned for as part of a long-term self-management strategy. In an emergency department cohort, recurrence rates range from 35% to 44%, depending on the definition used, with significantly higher rates observed among patients classified as high risk by the StartBack screening tool, a validated risk stratification instrument discussed in detail in Module 6, at 43% to 56% for high-risk patients, compared to 29% to 37% for low-risk patients. Prognostic factors for recurrence include frequent exposure to awkward postures, prolonged sitting exceeding 5 hours per day, more than 2 previous episodes of low back pain, older age, higher perceived risk of persistent pain, and greater baseline disability. These prognostic factors give clinicians actionable targets for recurrence prevention counseling and intervention. In patients with established chronic low back pain, the course is often persistently symptomatic. A population-based cohort study found that 63% of chronic low back pain patients followed a persistent course with pain present at all time points over 5 years, while 37% followed a relapsing course with alternating periods of pain and relative remission. Having a manual occupation was independently associated with a 46% increased risk of following a persistent pain course. These findings reinforce the recurrent and often persistent nature of low back pain and highlight the need for long-term management strategies that extend well beyond the acute treatment episode. A notable advancement in recurrence prevention is the walk-back randomized controlled trial, which showed that an individualized progressive walking and education intervention significantly reduced recurrence risk compared to usual care. The intervention reduced the risk of recurrence by approximately 28%, a finding that was statistically robust and almost certainly not attributable to chance, and the median time to recurrence extended from 112 days in the control group to 208 days in the intervention group. This trial provides Level 1 evidence supporting a simple, low-cost, and widely accessible intervention that can be readily implemented across diverse clinical settings to meaningfully reduce the burden of recurrent low back pain. The proportion of acute low back pain cases that progress to chronic symptoms has been revised substantially upward in recent years, and this represents one of the most clinically significant updates in the contemporary low back pain literature. While traditional estimates suggested that only 5% to 10% of acute episodes would transition to chronicity, contemporary prospective cohort studies show the true rate is considerably higher, with 25% to 45% of acute cases progressing to chronic low back pain. A landmark U.S. prospective cohort study of 5,233 patients across 77 primary care sites documented an overall unadjusted transition rate of 32%, with stratified rates of 19% in the low-risk group, 33% in the medium-risk group, and 49% in the high-risk group. The American Academy of Family Physicians has documented that the transition rate increased from an estimated 26% in 2010 to 32% in 2019, suggesting a potentially growing burden of chronicity in the United States. A 2025 prospective longitudinal cohort study further showed that the measured transition rate is sensitive to the operational definition of acute low back pain used at baseline, varying from 35.8% to 45.6% depending on the definition employed. So what does that mean in practice? Approximately 1 in 3 patients presenting with acute low back pain in primary care will develop chronic symptoms, and risk stratification at the time of initial presentation is essential for identifying patients who may benefit from earlier, more intensive intervention. The risk factors associated with the transition from acute to chronic low back pain span biological, psychological, and social domains, reflecting the inherently biopsychosocial nature of this condition. Among clinical predictors, higher baseline pain intensity and greater functional disability are the most consistent predictors of chronicity across multiple studies. Psychological factors, including depression, anxiety, pain catastrophizing, negative recovery expectations, and maladaptive coping strategies, consistently emerge as potent and independent predictors of the transition to chronic pain, as discussed in detail in Module 6. The IDRIS prospective cohort study identified dysfunctional symptom expectations measured at 1 month as the single strongest predictor of chronic pain at 3 months, a finding that was highly statistically significant and almost certainly not attributable to chance. That highlights the powerful prognostic role of patient cognitions early in the course of an acute episode. These findings point to the critical importance of early psychological screening and targeted cognitive behavioral intervention during the acute phase. Occupational factors represent another critical risk domain. Manual labor, heavy lifting, prolonged sitting, and poor job satisfaction are each independently associated with increased risk of chronicity. Having a manual job has been independently associated with a 46% increased risk of following a persistent pain course, highlighting the need for workplace assessment and modification as part of thorough low back pain management. Demographic and lifestyle factors including female sex, older age, obesity, smoking, sedentary lifestyle, and previous episodes of low back pain, especially those lasting more than 30 days, further contribute to chronicity risk. An umbrella review of biopsychosocial factors for chronicity confirmed that no single domain adequately explains the acute-to-chronic transition, and that interactions between domains, particularly between psychological distress and occupational demands, amplify risk beyond what either domain predicts independently. This has important implications for clinical screening, suggesting that multidimensional assessment tools capturing biological, psychological, and occupational factors at the same time may outperform single-domain screening approaches. Emerging neurobiological predictors have added a new dimension to our understanding of chronicity risk. A prospective cohort study found that lower sensory cortex and corticomotor excitability, combined with specific brain-derived neurotrophic factor genotypes, explained a meaningful additional share of the variation in 6-month pain intensity beyond what clinical and psychological factors alone could account for, achieving excellent predictive accuracy for future pain when combined with other known risk factors. Peripheral immune markers have also been identified as novel predictors. A U.S. cohort study showed that B-cell maturation trajectories and specific patterns of inflammatory cytokine production predict the transition from acute to chronic low back pain, providing early evidence for immunological biomarkers of chronicity risk. While these neurobiological and immunological predictors aren't yet ready for routine clinical application, the neuroplastic changes associated with chronic pain are discussed in Module 4. They point toward a future in which biological risk stratification may complement existing psychosocial screening tools. Contemporary clinical practice guidelines emphasize a consistent set of principles for the early management of acute low back pain, aimed specifically at preventing the transition to chronicity. Clinicians should provide reassurance about the generally favorable prognosis of acute low back pain, encourage patients to remain physically active and avoid bed rest, and prioritize non-pharmacologic therapies, including exercise, manual therapy, and patient education, as first-line treatments. When the patient and clinician determine that pharmacotherapy is appropriate, non-steroidal anti-inflammatory drugs are recommended as first-line agents, with the caveat that the magnitude of benefit is modest. Opioids are not recommended for acute low back pain due to the risk of dependence, the lack of evidence for long-term benefit, and the potential for opioids to impede natural pain resolution processes. The PACBAC randomized clinical trial provides important new evidence regarding early intervention for at-risk patients. This trial evaluated clinician-supported biopsychosocial self-management and spinal manipulation in 481 patients with acute low back pain who were at increased risk for developing chronicity. Supported biopsychosocial self-management resulted in a statistically significant reduction in disability over 1 year compared to medical care alone, with 67% and 65% of patients in the two self-management groups achieving a 50% or greater reduction in disability, compared to 54% in the medical care group. Spinal manipulation alone did not differ significantly from medical care. These findings provide level 1 evidence that early structured biopsychosocial self-management can meaningfully alter the trajectory of low back pain in patients identified as at risk for chronicity, reinforcing the importance of risk stratification and targeted early intervention as core components of routine clinical practice. Module 3 explores the neuroscience of pain, moving from basic nociceptive mechanisms through central sensitization to the emerging concept of nociplastic pain. The distinction between nociception and pain perception is foundational to understanding chronic low back pain and represents one of the most clinically consequential insights from contemporary pain neuroscience. Nociception refers to the neural encoding and transmission of noxious stimuli through specialized sensory neurons, a process that occurs at the periphery and along ascending spinal pathways. Pain perception, on the other hand, is the subjective, multidimensional experience arising from the integration of sensory discriminative, affective motivational, and cognitive evaluative processes within the central nervous system. These two phenomena are neurobiologically distinct. Nociception can occur without conscious pain perception, and pain can persist, often at debilitating intensity, in the complete absence of ongoing nociceptive input. This dissociation is a hallmark of chronic low back pain and provides the conceptual foundation for understanding why structural pathology identified on imaging frequently correlates poorly with the severity of a patient's reported pain experience. The clinical implications of this distinction are far-reaching and directly relevant to treatment selection. If pain were simply a faithful readout of peripheral tissue damage, then interventions targeting structural pathology, surgery, injections, tissue-directed manual techniques should reliably produce proportional pain relief, and interventions that don't address tissue-level processes should have no meaningful effect on the pain experience. Contemporary evidence shows precisely the opposite pattern. Psychological therapies, pain neuroscience education, and cognitive behavioral interventions can profoundly reduce both pain intensity and disability, while surgical interventions targeting structural pathology frequently fail to produce clinically meaningful improvement in symptoms. These findings compel us to move beyond a purely biomedical framework and adopt a broader neurobiological model that recognizes pain as an emergent property of central nervous system processing shaped by expectation, emotion, context, and prior experience, rather than a direct signal transmitted from damaged tissues to a passive brain. For allied health professionals, this isn't merely theoretical. It fundamentally alters the rationale for treatment, the content of patient education, and the criteria by which clinical success is measured. Although chronic low back pain is increasingly understood through the lens of central nervous system processing, peripheral nociceptive mechanisms continue to play an important role, particularly in the early stages of pain chronification and in the maintenance of nociceptive drive in certain patient subgroups. At the level of the dorsal root ganglion, or DRG, persistent mechanical and inflammatory stimulation induces plastic changes in sensory neurons, including upregulation of pain-associated genes, including ion channels and neuroinflammatory mediators. Single-nuclei RNA sequencing of DRG neurons in chronic discogenic low back pain models has confirmed that axial hypersensitivity is significantly correlated with increased expression of these pain-associated genes, providing molecular-level evidence for peripheral sensitization in chronic spinal pain. These molecular changes in peripheral sensory neurons contribute to heightened nociceptive signaling and can establish a self-perpetuating cycle of sensitization that extends well beyond the initial tissue injury. Macrophages infiltrating injured tissues and the dorsal root ganglion amplify this process by releasing pro-inflammatory cytokines, including tumor necrosis factor alpha or TNF-alpha, interleukin-1 beta or IL-1 beta, interleukin-6 or IL-6, and prostaglandin E2 or PGE2, perpetuating a pro-nociceptive inflammatory environment that maintains and potentially escalates nociceptive transmission. Systematic reviews confirm that patients with chronic low back pain exhibit significantly elevated levels of C-reactive protein, or CRP, IL-6, and TNF-alpha, alongside reduced levels of the anti-inflammatory cytokine interleukin-10, or IL-10, indicating a systemic shift toward a pro-inflammatory state. This cytokine imbalance isn't merely a biomarker of chronic pain, but appears to have genuine pathogenic significance, as it creates conditions conducive to ongoing peripheral sensitization even after the initial tissue insult has resolved. Prospective cohort data have added a critical temporal dimension to these findings by showing that distinct baseline plasma cytokine profiles can predict the transition from acute to chronic low back pain in a sex and age-specific manner. B-cell maturation trajectories have emerged as unique predictors of pain chronification that are independent of self-reported pain intensity, providing early evidence for immunological biomarkers that may eventually complement existing psychosocial screening tools for identifying patients at greatest risk of chronicity. The gut-brain immune axis has also emerged as a novel area of investigation, with accumulating evidence that microbiota composition influences pain susceptibility through immunomodulatory pathways, and that premature suppression of acute inflammation with nonsteroidal anti-inflammatory drugs or corticosteroids may paradoxically promote chronification by disrupting endogenous inflammatory resolution pathways. While these peripheral immune mechanisms aren't yet targets of routine clinical intervention, they highlight the biological complexity underlying the transition from acute to chronic pain and challenge simplistic models that attribute chronification solely to psychological or behavioral factors. Central sensitization represents the amplification of neural signaling within the central nervous system that results in pain, hypersensitivity disproportionate to any identifiable peripheral nociceptive input. This process involves multiple interacting mechanisms at the level of the spinal cord and brain, including long-term potentiation, a persistent strengthening of synaptic connections that amplifies signal transmission in spinal dorsal horn neurons, activation of microglia and astrocytes, the resident immune and support cells of the central nervous system, with subsequent release of pro-inflammatory mediators that alter neuronal excitability and progressive dysfunction of descending inhibitory pathways that normally serve to dampen nociceptive transmission from the periphery. The cumulative result is a state in which the central nervous system generates and maintains pain that's no longer an accurate representation of peripheral tissue status, a fundamental shift from the acute nociceptive pain that characterizes the initial phase of tissue injury. Understanding this shift is essential for clinicians because it explains why treatments directed exclusively at peripheral structures often fail in patients with established central sensitization, and why centrally directed therapies may succeed where tissue-targeted approaches have not. Clinical measurement of central sensitization has become increasingly practical through the Central Sensitization Inventory, or CSI, a validated self-report questionnaire that assesses a cluster of symptoms commonly associated with central sensitization syndromes. Higher CSI scores are independently associated with an increased risk of developing chronic low back pain, with each additional point on the CSI slightly but reliably increasing that risk, a finding that was statistically significant and unlikely to be due to chance. They're also associated with greater pain intensity and higher levels of disability. While this per-unit effect appears modest, the cumulative risk across the full CSI scoring range is clinically meaningful, and the association is independent of baseline pain intensity. Central sensitization severity is also closely linked to a constellation of comorbid features, including poor sleep quality, elevated psychological distress, elevated morning cortisol levels, and deficits in visuospatial working memory. These multidimensional associations highlight the systemic nature of central sensitization and its intersection with sleep physiology, neuroendocrine function, and higher-order cognitive processing, reinforcing the principle that chronic pain is a whole-person experience that can't be reduced to any single neurobiological pathway. A critical question for clinical practice concerns the relative contributions of different factors to the chronic low back pain experience. A multivariate meta-analysis directly addressing this question found that psychosocial factors exert the largest influence on chronic low back pain outcomes, with a large and clinically meaningful effect that was robust across the studies analyzed, substantially exceeding both nervous system biomarkers, which showed a small effect, and spinal imaging biomarkers, which showed a moderate effect. The gap between the psychosocial and nervous system domains was statistically significant and almost certainly not attributable to chance, with psychosocial factors showing roughly 3 times the influence of nervous system measures alone. These findings don't diminish the importance of neurobiological mechanisms, but rather situate them within a broader biopsychosocial context in which psychological and social factors are the dominant drivers of clinical outcomes. The American Academy of Family Physicians emphasizes that the nociplastic changes characteristic of central sensitization are reversible with sustained multimodal interventions, a therapeutic message that offers genuine hope for patients who may have been told that their pain is permanent or all in their head. At the supraspinal level, chronic low back pain is associated with measurable alterations in brainstem and cortical pain processing that provide objective neurobiological evidence for the subjective experience reported by patients. Magnetic resonance spectroscopy, or MRS, studies of the periaqueductal gray, or PAG, the principal brainstem hub for descending pain modulation, show a significantly lower excitatory to inhibitory neurotransmitter ratio in patients with chronic low back pain compared to healthy controls, a finding that was statistically significant and very unlikely to be due to chance, driven by both decreased glutamate concentration and increased GABA concentration. These neurochemical alterations are associated with impaired descending pain inhibition and increased pain sensitivity, providing a concrete neurobiological substrate for the clinical observation that chronic low back pain patients experience heightened and disproportionate pain responses to stimuli that wouldn't be painful in healthy individuals. Combined resting state, functional MRI, and MRS studies reveal complementary cortical changes, including reduced functional integration and a shift toward higher frequency oscillatory activity within the salience network, a brain network responsible for detecting and filtering stimuli that demand attention, particularly in the anterior insula and anterior mid-cingulate cortex. These salience network alterations reflect an impaired capacity to appropriately evaluate and prioritize sensory information, contributing to the heightened attention to and amplification of pain-relevant signals that characterize the chronic pain state. Contemporary predictive processing frameworks provide a compelling theoretical context for these findings, positing that the brain continuously generates expectations about bodily states and compares these predictions against incoming sensory data. In chronic pain, maladaptive prior expectations and aberrant salience attribution lead the brain to persistently generate pain perception, even when peripheral nociceptive input has diminished or resolved entirely, creating a self-reinforcing loop of anticipated and experienced pain. The recognition that chronic pain can arise from altered nociceptive processing in the absence of clear evidence of tissue damage or somatosensory disease led the International Association for the Study of Pain, or ISP, to introduce nociplastic pain as a third mechanistic descriptor, alongside the established categories of nociceptive and neuropathic pain. This classification has fundamentally altered the diagnostic framework for chronic low back pain by providing a mechanistic category for the large proportion of patients whose pain can't be adequately explained by identifiable structural pathology or nerve damage. Clinical criteria for nociplastic pain require chronic pain persisting for at least 3 months, a regional pain distribution not fully explained by nociceptive or neuropathic mechanisms, clinical signs of pain hypersensitivity in the affected region, and the presence of comorbid symptoms such as fatigue, sleep disturbance, or cognitive dysfunction. Neuropathic pain, the second mechanistic category in the IASP framework, is defined as pain caused by a lesion or disease of the somatosensory nervous system. In the context of low back pain, neuropathic mechanisms are most commonly associated with lumbosacral radiculopathy, in which nerve root compression or inflammation produces pain, radiating along a dermatomal distribution, often accompanied by sensory changes such as numbness or paresthesia, motor weakness, and diminished reflexes. The BAC-PAP Consortium's clinical assessment framework distinguishes neuropathic low back pain from nociceptive and nociplastic presentations by requiring evidence of a relevant neurological lesion affecting the somatosensory system, with a neuroanatomically plausible pain distribution confirmed through clinical examination. Identifying a neuropathic component carries direct treatment implications, as these patients may respond more favorably to pharmacologic agents targeting neuropathic mechanisms, including gabapentinoids and serotonin norepinephrine reuptake inhibitors, and may benefit from targeted evaluation of the underlying neural pathology. Recognition of neuropathic features is also important for accurate pain phenotyping, as mixed presentations involving nociceptive, neuropathic, and nociplastic components are common in chronic low back pain and require correspondingly multimodal management strategies. The BAC-PAP Consortium, comprising 36 international experts from 13 countries, published consensus recommendations for identifying the dominant pain phenotype in chronic low back pain through a stepwise clinical assessment that integrates clinical history, physical examination findings, and validated screening instruments. The consortium explicitly cautions that these recommendations aren't yet ready for routine clinical implementation and should be viewed as a framework for advancing clinical phenotyping research rather than as definitive diagnostic criteria. Field studies evaluating the IASP grading system for nociplastic pain have shown high specificity, meaning very few false positive diagnoses at 89 to 93%, but only moderate sensitivity, meaning some true cases are missed at 60 to 69%. That tells us the criteria are reliable for confirming nociplastic pain when met, but they may under-identify patients who have clinically significant nociplastic features. In one community physiatry clinic study, 88% of patients presenting with chronic back or neck pain met criteria for primary nociplastic pain, despite nearly universal structural imaging abnormalities. 97.7% of these patients had at least one spinal anomaly on imaging. That finding powerfully illustrates the disconnect between structural imaging pathology and the actual pain mechanism driving clinical symptoms, and it highlights the critical importance of mechanism-based clinical assessment rather than imaging-driven diagnosis. The classification of pain mechanism carries direct and actionable treatment implications. Patients with a predominantly nociplastic pain phenotype are less likely to benefit from interventions targeting peripheral nociceptive sources, such as corticosteroid injections and surgical decompression, and are more likely to respond favorably to centrally acting therapies, including pain neuroscience, education, cognitive behavioral therapy, graded exposure and exercise, and pharmacologic agents such as serotonin norepinephrine, reuptake inhibitors, and gabapentinoids. Positron emission tomography, or PET, imaging using translocator protein, or TSPO ligands, has further clarified the neurobiological basis of nociplastic pain by revealing elevated neuroinflammatory signals in the brains, spinal cords, and neuroforamina of patients with chronic low back pain, with spatial distribution patterns showing disorder-specific characteristics. The neuroimaging details of these neuroinflammatory signatures, including subtype-specific differences between radicular and axial pain and their correlation with widespread pain sensitivity, are discussed in Module 4. These neuroimaging advances confirm the biological reality of nociplastic pain, validate the subjective experience of patients whose pain has often been dismissed, and provide a growing evidence base for mechanism-based treatment selection in routine clinical practice. Module 4 examines the neuroplastic brain changes associated with chronic low back pain, advances in functional neuroimaging, quantitative sensory testing findings, and the critically important evidence for reversibility. Chronic low back pain is associated with measurable structural changes in the brain that reflect the neuroplastic reorganization induced by persistent pain states. Structural MRI studies consistently identify decreased gray matter volume in the dorsolateral prefrontal cortex, or DLPFC, thalamus, temporal lobes, insula, and primary somatosensory cortex in patients with chronic low back pain. Systematic reviews have found that the majority of structural MRI studies, 10 of 15 in one thorough analysis, demonstrate decreased gray matter in these regions, while 7 of 8 studies evaluating white matter integrity identified significant alterations. And here's what's clinically important. These structural brain changes are now interpreted as neuroplastic reorganization rather than irreversible atrophy. That distinction matters because it implies these alterations may be at least partially reversible with effective treatment. In patients with chronic nonspecific low back pain, decreased gray matter volume has been specifically documented in the left precentral gyrus, lingual gyrus, and right cerebellar CRUS1, with these changes correlating significantly with pain intensity, disability, anxiety, and depression. In neuropathic chronic low back pain phenotypes, extensive thalamic shape changes distinguish neuropathic from non-neuropathic subtypes, suggesting that different pain mechanisms produce distinct structural neuroplastic signatures that may eventually aid in clinical phenotyping. White matter diffusion tensor imaging, or DTI, studies show increased anatomical connectivity of the left thalamomotor pathway, reflecting altered communication between thalamic relay centers and motor cortical regions. Sensoromotor cortical reorganization is perhaps the most consistently reported finding. Individuals with recurrent or persistent low back pain show altered somatotopic representation in the primary somatosensory and motor cortices. Critically, these changes persist between symptomatic episodes, suggesting they represent a stable trait-level alteration rather than a transient state phenomenon. This persistence of cortical reorganization during pain-free intervals has important implications for understanding why low back pain recurs. The brain retains a neural imprint of the chronic pain experience that may predispose to future episodes even after symptoms have resolved. Functional neuroimaging has provided complementary insights into the dynamic brain changes associated with chronic low back pain. Resting state functional MRI studies show increased amplitude of low-frequency fluctuations, or ALFF, and regional homogeneity in regions comprising the extended pain matrix, including the insula, anterior cingulate cortex, thalamus, and somatosensory cortices. Patients with chronic low back pain exhibit significantly higher ALFF in multiple brain regions, with altered precuneus activity showing a particularly informative pattern. Precuneus ALFF shows a moderately strong positive relationship with pain intensity, meaning that greater precuneus activity tracks closely with worse pain, and a moderately strong inverse relationship with pain sensitivity thresholds, meaning that greater precuneus activity is associated with heightened pain sensitivity. Mediation analysis confirms that the effect of altered precuneus ALFF on pain intensity is mediated through changes in pain threshold. These findings suggest that altered intrinsic brain activity in regions involved in self-referential processing and body schema representation contributes directly to the pain experience in chronic low back pain. At the network level, enhanced connectivity between the frontoparietal network, somatomotor network, and thalamus represents the most significant functional network change in chronic low back pain, achieving near-perfect diagnostic accuracy for classifying patients with chronic low back pain versus healthy controls in research settings. That's a remarkably high discriminative accuracy, and it shows how strong these network-level alterations are. Reduced connectivity between the ventral tegmental area and mesocortical limbic reward pathways is associated with increased pain sensitivity and greater pain severity, reflecting dysfunction in the brain's reward and motivational circuitry. The transition from acute to chronic low back pain is marked by a progressive shift in supraspinal processing from sensory discriminative to effective limbic dominance, with greater involvement of the medial prefrontal cortex, nucleus accumbens, amygdala, and hippocampus. Resting state functional MRI has identified the medial prefrontal cortex and rostral anterior cingulate cortex as a critical hub, with connectivity patterns discriminating patients with chronic low back pain from controls with 91% accuracy in one cohort and 78% in a validation cohort. Particularly relevant is the finding that all 14 resting state functional MRI studies in one systematic review reported differences between chronic low back pain and control groups in the default mode network, while only 3 of 10 task-based functional MRI studies observed significant differences during noxious stimulation. That suggests brain changes in chronic low back pain are predominantly in areas important for emotion and cognition rather than nociception. Neurochemical and neuroimmune imaging techniques have added a further dimension to our understanding of the central changes in chronic low back pain. PET imaging using TSPO radioligands reveals elevated neuroinflammatory signals in patients with chronic low back pain, especially prominent in primary somatosensory cortex, with TSPO PET signal and functional connectivity to the thalamus significantly higher in radicular compared to axial back pain patients. These neuroimmune signals are positively correlated with fibromyalgia scores, and mediation modeling shows that fibromyalgia mediates the association between TSPO PET signal and primary somatosensory cortex thalamus connectivity. These findings provide objective neurobiological evidence for the clinical observation that chronic low back pain, particularly when accompanied by widespread pain sensitivity features, involves measurable neuroinflammatory processes within the central nervous system. Quantitative sensory testing, or QST, provides a standardized psychophysical assessment of the sensory nervous system that can identify and quantify the somatosensory abnormalities characteristic of chronic low back pain. Several core QST findings have been consistently documented in patients with chronic low back pain, each reflecting a different aspect of altered central pain processing. Reduced pressure pain thresholds, or PPTs, are among the most reliable QST findings. Patients with chronic low back pain demonstrate significantly lower PPTs than pain-free controls at both local sites, the lumbar region, showing a clinically meaningful reduction in pain pressure tolerance, and remote sites, including the tibialis anterior muscle, where pain thresholds are also meaningfully reduced compared to pain-free individuals. Meta-analytic data confirm that PPTs at the scapula are also significantly lower in chronic low back pain patients, with an even larger reduction than at the tibialis anterior. The presence of widespread pressure, hyperalgesia, at sites remote from the lumbar spine provides strong evidence for central sensitization rather than localized peripheral pathology. The pressure pain detection threshold at the site of most severe pain has achieved the strongest diagnostic performance among all QST parameters for discriminating chronic low back pain patients from healthy controls, making it the single most diagnostically useful QST measure. Enhanced temporal summation of pain, or TSP, reflecting facilitated windup, which is a progressive increase in pain signaling that occurs when stimuli of the same intensity are repeated, of spinal dorsal horn neurons, is significantly increased in both acute and chronic low back pain patients relative to controls. Baseline TSP has meaningful prognostic value, with higher temporal summation at initial assessment consistently predicting greater musculoskeletal pain intensity at follow-up. Impaired conditioned pain modulation, or CPM, which reflects dysfunction of descending inhibitory pathways, is another hallmark finding. During CPM testing, patients with chronic low back pain demonstrate meaningfully reduced capacity to engage endogenous pain inhibition, showing substantially lower pressure pain thresholds during the conditioning paradigm compared to healthy controls. Baseline CPM similarly predicts follow-up pain, and females with chronic low back pain and comorbid insomnia exhibit particularly impaired CPM, highlighting the interaction between sleep disturbance and descending pain modulation. CPM impairment has been shown to persist even during pain-free periods in patients with recurrent low back pain, suggesting it represents a stable trait marker of altered central pain processing, rather than a transient state associated with active pain. Pain catastrophizing is strongly linked to CPM efficiency, with a strong inverse relationship showing that higher levels of catastrophizing are closely associated with less effective descending inhibition, a finding that was highly statistically significant and almost certainly not due to chance. Slowly repeated evoked pain, or SREP, is an emerging QST approach that may capture additional aspects of central sensitization. Patients with chronic low back pain show increasing pain ratings to SREP, while healthy individuals show decreasing ratings, a divergent pattern that distinguishes the two groups. SREP distinguishes chronic low back pain from healthy controls with moderate accuracy, with a sensitivity of 77.5% and specificity of 60%. Together, these converging QST abnormalities, widespread pressure hyperalgesia, facilitated temporal summation, impaired conditioned pain modulation, and enhanced slowly repeated evoked pain, provide a thorough psychophysical profile of the altered central pain processing that characterizes chronic low back pain. Pressure pain thresholds and functional capacity measures together account for a substantial portion of the variation in lumbar pain severity, confirming the clinical relevance of these somatosensory measures. Preoperatively, higher CSI scores, especially 40 or above, and abnormal QST findings are consistently associated with worse postoperative outcomes, with central sensitization prevalence ranging from 10 to 20% in preoperative populations. These findings have important implications for surgical decision-making, as they suggest that patients with significant central sensitization may respond poorly to procedures targeting peripheral structural pathology. Now that we've established the scope of brain changes associated with chronic low back pain, here's a critically important finding from the neuroplasticity literature. The structural and functional brain changes associated with chronic low back pain are not permanent. Research has shown that successful treatment can lead to significant increases in cortical thickness in the left DLPFC and primary motor cortex at 6-month follow-up, with increased DLPFC thickness correlating with reductions in both pain intensity and physical disability. This evidence of treatment-induced cortical recovery provides a powerful basis for patient education and for the therapeutic message that the brain changes associated with chronic pain can be reversed. Pain reprocessing therapy, or PRT, a psychological intervention that teaches patients to reappraise pain signals as non-dangerous, has produced some of the most striking evidence for neuroplastic reversal. In a landmark randomized controlled trial, 66% of PRT participants were pain-free or nearly pain-free at post-treatment, compared to 20% in the placebo group and 10% in the usual care group, with large effect sizes maintained at 1-year follow-up. Functional MRI revealed that PRT produced reduced pain-evoked responses in the anterior mid-cingulate cortex and anterior prefrontal cortex, accompanied by increased resting state connectivity between prefrontal regions and the somatosensory cortex, providing direct neuroimaging evidence of treatment-induced changes in pain processing circuits. These findings show that a targeted psychological intervention can produce both clinical and neurobiological recovery in patients with chronic low back pain. Manual therapy has also been shown to produce measurable changes in brain connectivity. Spinal manipulation increased salience network connectivity to the thalamus and lateral prefrontal cortex, with connectivity changes very strongly associated with pain reduction, indicating a close and direct relationship between the brain changes produced by manipulation and the degree of clinical improvement. Pain neuroscience education combined with cognition-targeted motor control training has shown statistically significant advantages over best evidence physiotherapy alone in reducing pain, improving functionality, and modifying maladaptive pain cognitions in a multi-center randomized controlled trial of 120 participants. These multimodal findings suggest that effective interventions, whether psychological, manual, or educational, can engage overlapping neural mechanisms to reverse the maladaptive neuroplastic changes that characterize chronic low back pain. Sex and age differences in neuroplasticity are clinically relevant considerations. Women with chronic low back pain demonstrate shape deformation in the anterior left hippocampus not observed in men, and exhibit greater involvement of sensoromotor and effective limbic circuits, along with unique neuroimmune pathways involving adaptive immune T-cell and astrocyte-mediated mechanisms. Men, by contrast, display predominantly microglial-driven neuroinflammation. Genetic heritability of chronic back pain is also higher in females than males, with largely non-overlapping risk loci between sexes. Older adults exhibit genuine deterioration of descending pain inhibitory mechanisms, with diminished conditioned pain modulation responses in older adults compared to younger adults, a finding that has implications for managing chronic low back pain in aging populations. Emerging neuromodulatory therapies represent a frontier in chronic low back pain management. Infraslow neurofeedback targeting the pregenual anterior cingulate cortex has shown clinically meaningful reductions in pain severity in 53% of participants, with a mean reduction of nearly 2 points on a 0 to 10 pain scale, and 80% showing improvement in pain interference and 73% in disability, with no adverse events. Non-invasive brain stimulation modalities, including repetitive transcranial magnetic stimulation, or RTMS, transcranial direct current stimulation, or TDCS, and intermittent theta burst stimulation, or ITBS, have been investigated for chronic low back pain, though the evidence base remains limited and insufficient to recommend routine clinical use. Transcranial-focused ultrasound represents an emerging technology with early evidence suggesting rapid improvements in chronic pain, and the broader reconceptualization of chronic pain as a brain network disorder is expected to drive continued development of targeted neuromodulatory approaches in the coming years. Module 5 addresses one of the most significant evidence practice gaps in low back pain management: the relationship between structural imaging findings and clinical symptoms, along with the nocebo effects of diagnostic labeling and current imaging guidelines. The disconnect between structural imaging findings and clinical symptoms is one of the most significant evidence practice gaps in contemporary low back pain management. Systematic review data covering over 3,100 asymptomatic individuals have established that degenerative spinal changes on magnetic resonance imaging are remarkably common in adults with no history of low back pain, with prevalence rates that increase predictably with age, findings that have been consistently validated in contemporary population-based cohort studies. Disc bulges are present in approximately 30% of asymptomatic adults in their 20s, increasing progressively to 40% in the 30s, 50% in the 40s, 60% in the 50s, and exceeding 80% by the 8th decade. Disc protrusions follow a similar age-related gradient, rising from approximately 29% in the 20s to 43% in the 80s, while annular fissures increase from 19% to 29% across the same age span. Facet arthrosis is present in fewer than 10% of adults in their 20s, but exceeds 50% by the 5th decade, and spondylolisthesis, though less prevalent, increases from approximately 2% to 8% over the lifespan. These findings show that the structural changes clinicians routinely identify on imaging and frequently cite as the cause of a patient's pain represent age-related normative changes rather than pathological abnormalities in the vast majority of cases. Modic changes, signal intensity alterations in vertebral end plates and adjacent bone marrow, warrant particular attention because of their unique prevalence pattern and clinical associations. Unlike most degenerative findings, modic changes demonstrate a non-linear age distribution, with peak prevalence in the 60s at approximately 44% and decline thereafter, suggesting that these changes don't simply accumulate with age. Among the various MRI findings, modic type 1 changes show the strongest and most consistent association with low back pain. A 2025 systematic review found that patients with modic type 1 changes were roughly 7 times more likely to have chronic low back pain compared to those without these changes, a finding that was statistically robust and reliable across the studies analyzed. However, the clinical significance of individual MRI findings remains limited in isolation. Population-based data show that almost all individual finding effect sizes translate to less than 1 unit on a 0 to 10 pain scale, indicating minimal clinical impact at the level of any single structural abnormality. The concept of cumulative imaging burden has emerged as a more clinically meaningful framework than any individual finding. A systematic review of 49 studies evaluating composite MRI scores concluded that most studies reported stronger associations between increasing sum scores of degenerative findings and low back pain than any individual finding alone. Individuals with 3 or more different MRI findings demonstrate substantially elevated odds of low back pain and markedly increased risk of recurrence compared to those with no findings. These data suggest that while any single MRI finding is a poor predictor of pain, the aggregate burden of structural changes may carry greater clinical relevance, though even cumulative burden measures haven't demonstrated reliable predictive value for future pain episodes. Longitudinal cohort studies following adults over periods of 6 to 10 years have consistently found that most individual baseline MRI findings were not associated with future low back pain severity, and that neither baseline findings nor their progression predicted future pain development. Multi-level disc degeneration and herniation show stronger cross-sectional associations with disabling low back pain, with roughly 5 to 6-fold higher odds of disabling symptoms in affected individuals. Yet these associations don't translate into reliable longitudinal prediction. These longitudinal data provide particularly compelling evidence against the use of routine imaging as a prognostic tool and challenge the clinical assumption that structural deterioration inevitably leads to worsening symptoms. The way clinicians communicate imaging findings and diagnostic labels to patients has measurable and consequential effects on pain outcomes, beliefs, and healthcare use. The specific terminology used to describe a patient's condition significantly influences their perception of seriousness, their expectations for recovery, and their treatment-seeking behavior going forward. In a study of 1,375 participants, pathoanatomical labels such as disc bulge, degeneration, and arthritis led to significantly higher perceived need for imaging, 5.7 to 6.0 on a 0 to 10 scale, compared to non-structural labels including episode of back pain, lumbar sprain, and non-specific low back pain at 4.2 to 4.4. These pathoanatomical labels also increased the perceived seriousness of the condition, reduced recovery expectations, and increased the desire for surgical intervention. A complementary content analysis revealed that labels such as disc bulge and degeneration evoked themes of poor prognosis, permanent tissue damage, and progressive deterioration, while non-specific low back pain didn't trigger these catastrophic interpretations and surgery didn't emerge as a treatment option for non-structural labels. The impact of maladaptive imaging beliefs extends well beyond the immediate clinical encounter. Prospective data show that each additional maladaptive imaging belief slightly but significantly increases pain interference at 6 weeks, contributing to a self-reinforcing cycle in which negative beliefs about structural findings amplify the pain experience and drive further help-seeking behavior. These findings are consistent with the broader predictive processing framework, in which strong negative prior expectations, beliefs that structural findings indicate serious, irreversible damage, dominate over actual sensory input, and generate sustained pain perception, even when the objective threat is minimal. The downstream healthcare consequences of inappropriate early imaging are substantial. Clinical practice guideline analyses have established that early MRI performed within the first 6 weeks of an acute low back pain episode in the absence of red flags is associated with a 13-fold increase in the likelihood of lumbar surgery, greater opioid use, higher final pain scores, and significantly increased acute care costs. The entire diagnostic cascade initiated by early imaging, from specialist referral to interventional procedures to surgery, represents a self-amplifying cycle in which each step increases the probability of the next, ultimately resulting in greater cost, greater exposure to procedural risks, and no improvement in patient outcomes. The neurobiological mechanisms underlying nocebo effects provide a mechanistic explanation for these clinical observations. Negative expectations triggered by alarming diagnostic labels activate anticipatory anxiety pathways and the hypothalamic-pituitary-adrenal axis, increasing cortisol levels and enabling pain transmission through cholecystokinin-mediated pathways, while functional neuroimaging shows that nocebo responses increase neural activity in the prefrontal cortex, insula, amygdala, and anterior cingulate cortex, regions critically involved in pain processing and effective evaluation. Current clinical practice guidelines from 2022 through 2026 are unanimous in their recommendation against routine lumbar imaging for nonspecific low back pain in the absence of red flag findings. The American Academy of Family Physicians states that plain radiographs should not be ordered routinely except when there is clinical suspicion for trauma or osteoporotic fracture. The Department of Veterans Affairs and Department of Defense Clinical Practice Guideline explicitly recommends against early imaging within the first 6 weeks of symptoms, citing that the harms of routine imaging, including nocebo effects, unnecessary downstream interventions, and increased costs, outweigh any potential benefits. International guidelines from Australia, Canada, and the United Kingdom are fully concordant with these recommendations, reflecting a global consensus that routine imaging for nonspecific low back pain represents low-value care. Imaging is appropriate and indicated when specific red flag criteria are present. For suspected spinal malignancy, the combination of a history of cancer with clinical suspicion is by far the most diagnostically powerful indicator, making the diagnosis many times more likely than any other individual clinical feature. And imaging should be pursued when unexplained weight loss, age greater than 50, or failure to improve after 1 month accompanies a cancer history. For suspected spinal infection, fever combined with immunosuppression, intravenous drug use, or an indwelling vascular catheter warrants urgent imaging. For vertebral fracture, significant trauma or minor trauma in the setting of osteoporosis justifies imaging. For suspected cauda equina syndrome characterized by new-onset urinary retention, saddle anesthesia, fecal incontinence, or severe progressive neurological deficits, emergent MRI is indicated. When imaging is warranted, MRI without contrast is the preferred modality, and imaging may also be considered after 6 to 8 weeks of failed conservative management when clinical reassessment suggests the need for further evaluation. The consequences of deviating from these guidelines are substantial and well documented. As discussed in Module 1, the overuse of interventional procedures for low back pain, including high volumes of facet injections and neurotomy procedures, and spinal fusion surgeries with frequently unsatisfactory outcomes, contributes substantially to the economic burden. Unnecessary lumbar imaging alone is estimated to cost the U.S. healthcare system approximately $300 million per year. A systematic review and meta-analysis concluded that routine imaging did not improve pain, function, quality of life, or overall improvement compared to management without imaging, providing Level 1 evidence that guideline-concordant care doesn't compromise patient outcomes. Despite these clear guideline recommendations, approximately 34.8% of lumbar imaging referrals in primary care have been judged inappropriate by clinical guideline criteria, while imaging was not performed in 65.6% of patients who presented with legitimate red flags. That's a dual pattern of both overuse and underuse that shows the complexity of the implementation challenge. Key barriers to guideline concordant imaging include clinician fear of missing serious pathology, patient demand and expectations, insufficient time to provide adequate counseling and reassurance, and limited access to conservative management alternatives. Evidence-based strategies for mitigating the nocebo effects of diagnostic labeling and promoting guideline concordant care span the domains of clinical communication, imaging reporting, and patient education. The most immediate and actionable strategy is adopting neutral diagnostic language in clinical encounters. Research shows that non-structural labels such as episode of back pain or lumbar sprain produce significantly less catastrophizing, lower perceived seriousness, stronger recovery expectations, and reduced desire for imaging and surgery compared to pathoanatomical labels such as disc bulge or degeneration. Clinicians should systematically replace alarming structural terminology with language that normalizes the patient's experience and conveys the benign, self-limiting nature of most low back pain episodes. Modification of imaging reports and clinician communication practices represents another evidence-based approach. Adding benchmark prevalence data to spine imaging reports, informing clinicians and patients that the structural findings identified are also common in individuals without pain, has been shown to reduce spine-related healthcare use and opioid prescriptions in randomized controlled trial evidence. Including an epidemiologic context statement in imaging reports has been associated with meaningful reductions in specialist referrals and repeat imaging, showing that relatively simple modifications to radiology reporting can interrupt the downstream cascade of unnecessary care. Clinician training and standardized communication strategies for watchful waiting has also shown efficacy, with randomized trial data confirming that structured communication training significantly reduced early imaging rates. Positive framing of clinical information, emphasizing the favorable natural history, the high prevalence of imaging findings in pain-free individuals, and the reversibility of pain states, provides an important counterbalance to the nocebo effects of pathological labeling. Educating patients directly about the nocebo phenomenon, including how negative expectations can amplify pain perception through identifiable neurobiological mechanisms, has emerged as a promising intervention strategy. Open-label counter-conditioning, in which patients are given a benign stimulus paired with positive outcomes after having been exposed to negative expectations, has shown a large and clinically meaningful effect for attenuating nocebo-induced pain amplification in experimental paradigms, suggesting that experiential learning can effectively overwrite maladaptive beliefs established by diagnostic labeling. Positive affect induction has also shown promise, with experimental evidence showing that the induction of positive emotional states can completely block verbally induced nocebo hyperalgesia. Together, these strategies provide clinicians with a full toolkit for minimizing the iatrogenic harm associated with structural diagnosis while maintaining appropriate diagnostic vigilance for the small minority of patients who harbor genuinely serious pathology. Module 6 examines the psychosocial risk factors that predict chronic pain development, known as yellow flags, along with additional biological and lifestyle risk factors, red flag screening for serious pathology, and validated clinical risk stratification tools. Psychosocial factors, collectively referred to as yellow flags in clinical screening, represent the most potent and consistently identified modifiable predictors of the transition from acute to chronic low back pain and of poor outcomes in established chronic pain. A thorough umbrella review of biopsychosocial factors for chronicity confirmed that no single biological or biomechanical domain adequately explains the transition to chronic pain, and that psychological and social factors consistently show the largest effects in predicting clinical outcomes. These findings are consistent with the multivariate meta-analytic data presented in Module 3, which showed that psychosocial factors exert a large and dominant influence on chronic low back pain outcomes, substantially exceeding that of nervous system biomarkers or spinal imaging findings. Fear avoidance beliefs are among the most extensively studied and clinically actionable psychological predictors. Systematic review evidence at moderate certainty shows that elevated fear avoidance beliefs more than double the probability of chronic pain development, with a dose-dependent relationship in which moderate and high fear avoidance beliefs about work are associated with progressively increasing odds of higher pain intensity and prolonged pain duration at 1 year. Fear avoidance beliefs exert their clinical impact through progressive avoidance of physical activity, physical deconditioning, and escalating functional limitation, creating a self-reinforcing cycle that perpetuates both pain and disability. Pain catastrophizing has been identified as the single psychological factor with the most consistent evidence of association with poor long-term outcomes across the chronic low back pain literature. Meta-analytic data confirm medium to large-sized associations between catastrophizing, fear of pain, and pain-related outcomes. And catastrophizing was among the strongest predictors of pain intensity at 6 months in a prospective cohort study that accounted for nearly half of the variation in pain outcomes and about a third of the variation in disability when combined with other psychosocial factors. Catastrophizing and functional impairment are also significant predictors of kinesiophobia, fear of movement or re-injury, suggesting mediation pathways through which cognitive distortions translate into movement avoidance and progressive functional decline. Depression and anxiety are strongly and independently associated with chronic low back pain outcomes. A systematic review and meta-analysis of 62 studies covering 63,326 participants found that depressive symptoms were associated with higher pain intensity, greater disability, and worse recovery in chronic low back pain cohorts. Here's what's particularly striking. The prognostic significance of psychological factors strengthens over time rather than diminishing. Depressive symptoms during the acute phase are the most consistent predictor of worse outcomes over 12 months, and psychological factors assessed at 3 months are more predictive than those assessed at baseline, suggesting a progressive entrenchment of psychological risk that highlights the importance of early and repeated screening. Mendelian randomization analyses, a research method that uses naturally occurring genetic variants as instruments to test whether a risk factor truly causes an outcome, have confirmed bidirectional causal associations between depression and chronic back pain, establishing that the relationship isn't merely correlational, but reflects genuine causal pathways operating in both directions. Two emerging psychological constructs have shown particular promise for refining clinical risk assessment: pain hypervigilance, the tendency to maintain excessive attentional focus on pain-related information, has been identified as a powerful predictor of both pain severity and pain interference at 6 months, with associations that remain strong after adjustment for baseline pain intensity. Dysfunctional symptom expectations, patients' beliefs about the likely future course of their symptoms, have shown striking predictive power, emerging as the single strongest independent predictor of chronic pain at 3 months in the IDRIS prospective cohort study, a finding that was highly statistically significant and almost certainly not attributable to chance. When dysfunctional expectations were included in multivariate models, other psychosocial variables didn't independently predict chronification, suggesting that expectations may represent a final common pathway through which multiple psychosocial risk factors exert their effects. These findings have important clinical implications. Directly addressing patients' expectations about their pain trajectory may be among the most efficient targets for preventing the transition to chronicity. The interactions and clustering of psychosocial risk factors amplify individual risk in a dose-response fashion. The cumulative burden of multiple adverse psychosocial exposures, particularly in the workplace, dramatically increases the risk of comorbid psychological distress, with the odds of depression roughly tripling with a single adverse psychosocial work exposure and rising to nearly tenfold when all 4 exposures are present simultaneously. Latent profile analysis, a statistical method that identifies distinct subgroups within a population based on shared characteristics, has identified 4 distinct psychosocial phenotypes among chronic low back pain patients, suggesting that the clinical population isn't homogeneous but rather comprises distinct subgroups with different risk profiles and potentially different optimal treatment approaches. These findings reinforce the clinical imperative for thorough, multidimensional psychosocial assessment rather than screening for any single risk factor in isolation. Moving on to additional risk factors beyond the psychosocial domain. Low socioeconomic status is consistently associated with both the development and persistence of chronic low back pain, with pooled evidence showing roughly a 1/3 increase in the odds of chronic pain among individuals of low versus high socioeconomic status. In the United States, the socioeconomic gradient is steep. Annual household income below $20,000 and less than a high school education are each associated with markedly elevated odds of chronic low back pain, and Medicaid coverage confers substantially higher risk compared to private insurance. Post-secondary education is independently protective, conferring reduced odds for both pain and disability at 3 months or later. Mendelian randomization studies confirm that genetically determined education, occupation, and income independently reduce low back pain risk, with obesity partially mediating the socioeconomic pathway. Occupational demands remain a critical and modifiable risk factor domain. Carrying heavy loads, working in difficult postures, lack of workplace recognition, and productivity-related income pressure each independently predict chronic low back pain incidence over 5 years. Meta-analytic data covering over 19,000 participants show that high workload, low overall job control, low decision authority, and low social support are each independently associated with chronic low back pain. Having a manual occupation has been independently associated with a 46% increased risk of following a persistent pain course, as documented in Module 2, reinforcing the importance of workplace assessment and modification as integral components of thorough management. Prior pain episodes represent one of the strongest and most consistent predictors of future low back pain, roughly doubling to quadrupling the odds of future episodes depending on the number and severity of prior occurrences. When low back pain history is included alongside neurobiological and psychological factors in predictive models, the resulting predictive accuracy is excellent, confirming the critical prognostic value of a thorough pain history. Sleep disturbance has emerged as both a risk factor for and a consequence of chronic low back pain. Baseline sleep problems increase chronic musculoskeletal pain risk by roughly 64% in the short term and 39% over the long term. Mendelian randomization confirms a bidirectional causal association between insomnia and low back pain, with the effect substantially stronger for insomnia predicting pain, nearly doubling the risk, than for pain predicting insomnia. Each standard deviation increase in sleep disturbance scores is associated with the largest increase in pain and disability scores among all modifiable risk factors studied, and poor sleep quality and short sleep duration explain up to 45% of income inequities in pain and 51% of income inequities in chronic pain. That's a finding with serious implications for health equity. Having examined the modifiable psychosocial, occupational, and lifestyle factors that predict chronic pain development, let's shift to a different but equally important clinical concern: identifying the small minority of patients with serious underlying pathology. While the vast majority of low back pain presentations reflect benign musculoskeletal conditions, clinicians must maintain vigilance for the small proportion of patients who harbor serious underlying pathology requiring urgent evaluation and treatment. Among patients presenting with low back pain, the prevalence of spinal malignancy is approximately 0.7%, spinal infection approximately 0.01%, vertebral compression fracture approximately 4%, and cauda equina syndrome approximately 0.04%. For suspected spinal malignancy, a history of cancer is the most diagnostically valuable individual clinical feature, with specificity approaching 99%. And when combined with clinical suspicion, this pairing very strongly increases the probability of malignancy, making it the single most powerful red flag combination for spinal cancer. Other commonly cited red flags for malignancy, including unexplained weight loss alone, age greater than 50, failure to improve after 1 month, and night pain, have limited diagnostic value in isolation and do little on their own to change the probability of malignancy unless combined with a cancer history or with each other. Clinicians should maintain a high index of suspicion, as misdiagnosis of spinal metastases as mechanical back pain has been documented in 40% to 70% of cases, highlighting the potentially life-threatening consequences of failing to pursue appropriate evaluation when red flags are present. For vertebral compression fractures, the most thorough synthesis of red flag diagnostic accuracy comes from a 2023 Cochrane systematic review, widely recognized as the gold standard for evidence synthesis in healthcare. In primary care settings, older age greater than 70 years strongly increases the probability of fracture, trauma increases the probability to varying degrees depending on severity and context, and corticosteroid use ranges from a moderate to very strong indicator depending on the clinical setting and duration of use. Cluster-based approaches substantially improve diagnostic accuracy beyond what any single red flag achieves. The combination of older age and female gender is a very strong indicator that makes fracture much more likely. and the presence of 4 or more of 5 specified red flags similarly provides strong diagnostic confidence. The head elevation test has shown high accuracy for vertebral compression fractures, correctly identifying over 92% of fractures while correctly ruling out the diagnosis in approximately 86% of patients without fractures, and when combined with closed fist percussion, detection accuracy increases to approximately 97%, providing clinicians with a practical bedside screening approach. Spinal infection, particularly epidural abscess, presents a unique diagnostic challenge because its classic clinical triad of focal back pain, fever, and neurological deficit is present in fewer than 20% of patients at the time of diagnosis. The most useful clinical features for identifying spinal infection include saddle anesthesia, which is the strongest single indicator, followed in diagnostic value by radicular pain, numbness, or paresthesia, and focal spine tenderness, each of which meaningfully increases the probability of infection when present. The absence of acute back pain is the most useful feature for making spinal infection less likely, substantially reducing the probability when this symptom is absent. Intravenous drug use combined with other infection sites and the presence of an indwelling vascular catheter each strongly increase the probability of spinal infection and should prompt urgent evaluation. A clinical prediction rule combining clustered findings has achieved excellent diagnostic performance, with a sensitivity of 97% and specificity of 77%, providing a practical framework for clinical decision-making when spinal infection is a diagnostic consideration. Cauda equina syndrome requires emergent evaluation and is characterized by bilateral leg pain, saddle anesthesia, urinary retention, fecal incontinence, and progressive bilateral neurological deficits. In an evaluation of 530 patients with suspected Cauda equina syndrome, bilateral leg pain and absent bilateral ankle reflexes were the clinical features most strongly associated with surgically confirmed cases, with absent bilateral ankle reflexes showing the stronger association of the two, though the overall ability of individual clinical features to discriminate confirmed from suspected cases was only moderate. Post-void residual volume greater than 200 milliliters was associated with confirmed Cauda equina syndrome in 43% of cases, while a post-void residual below 200 milliliters combined with the absence of objective neurological signs made the diagnosis rare. Digital rectal examination findings were not significantly associated with confirmed Cauda equina syndrome, challenging the traditional emphasis on this examination component in clinical practice. Clinicians should also maintain awareness of visceral and vascular conditions that can mimic low back pain, including pyelonephritis, nephrolithiasis, acute and chronic pancreatitis, peptic ulcer disease, endometriosis, ectopic pregnancy, and abdominal aortic aneurysm. Each of these conditions has characteristic features that distinguish it from musculoskeletal low back pain, such as pain unaffected by movement or position in aortic aneurysm, cyclic pain worsening with menstruation in endometriosis, or colicky flank pain radiating to the groin with inability to find a comfortable position in nephrolithiasis, and their recognition is essential for avoiding potentially life-threatening diagnostic delays. 2 validated risk stratification instruments are currently recommended for clinical use in low back pain management: the START-Back screening tool and the Orbro musculoskeletal pain questionnaire. The START-Back screening tool, or SBST, is a brief 9-item questionnaire that classifies patients into low, medium, or high-risk categories based on physical and psychosocial prognostic factors. The tool demonstrates acceptable discriminative accuracy for predicting disability outcomes in clinical validation studies. In a U.S. primary care validation study of 1,109 patients, 22% of low risk, 62% of medium risk, and 80% of high risk patients experienced persistent disabling back pain at 6 months, with medium risk patients nearly 3 times as likely, and high risk patients nearly 4 times as likely, to develop persistent disabling pain compared to the low risk group. The addition of a single workability item has been shown to meaningfully improve the tool's ability to predict disability, increasing the explained variance substantially and suggesting that occupational factors meaningfully improve risk prediction beyond the standard SBST items. The SBST demonstrates moderate internal consistency and good test-retest reliability. The Orbro Musculoskeletal Pain Questionnaire, or OMPQ, available in both a 25-item full version and a validated 10-item short form, provides complementary prognostic information. The OMPQ achieves acceptable predictive accuracy for disability and moderate accuracy for pain, but its particular strength lies in predicting work absenteeism, where it achieves strong predictive performance, a level categorized as excellent. At a cutoff score of 90, the OMPQ achieves a sensitivity of 89% and specificity of 65% for predicting work absenteeism, and a sensitivity of 74% and specificity of 79% for predicting functional outcomes. The 10-item short form maintains a very strong relationship with the full version and produces nearly identical predictive accuracy, supporting its clinical utility in time-constrained settings. Head-to-head comparisons of the two instruments reveal moderate correlation, but only moderate agreement in risk classification, indicating that they aren't interchangeable and capture partially different dimensions of risk. The SBST has significantly fewer scoring miscalculations in routine clinical use, an important practical consideration for busy clinical settings. Current clinical practice guidelines, including the VA, DoD, and the American Academy of Family Physicians, endorse both instruments with a week 4 recommendation, reflecting the evidence that while risk stratification tools provide useful prognostic information, their demonstrated ability to change patient outcomes when used to guide treatment allocation hasn't been definitively established. A large U.S. study of 1,701 patients didn't demonstrate a significant effect of SBST-guided screening on patient outcomes, tempering enthusiasm for universal screening while not negating the instrument's inherent prognostic utility. For primary care and disability prevention contexts, the SBST is generally preferred for its brevity, lower error rate, and acceptable discriminative accuracy for disability. For occupational health and return-to-work settings, the OMPQ is preferred for its superior prediction of work absenteeism. Neither tool reliably predicts persistent pain, which highlights the need for continued development of more thorough risk prediction models that integrate biological, psychological, occupational, and social factors into unified clinical algorithms. Module 7 examines the evidence base for pain neuroscience education, or PNE, optimal dosing and delivery strategies, effective clinical communication approaches, and implementation considerations. Pain neuroscience education has emerged as one of the most extensively studied non-pharmacological interventions for chronic low back pain, with a rapidly maturing evidence base that has clarified both its therapeutic potential and its limitations. The efficacy of PNE depends critically on the therapeutic context in which it's delivered, specifically whether it's provided as a standalone intervention or combined with active physical rehabilitation. When PNE is combined with exercise or physiotherapy, the evidence for clinically meaningful benefit is compelling. A dose-response meta-analysis of 26 randomized controlled trials covering 1,852 patients showed that PNE combined with exercise produced a mean reduction of 2.61 points on a 0 to 10 pain scale, exceeding the 2-point minimal clinically important difference, the smallest change a patient would recognize as meaningful, at a cumulative dose of approximately 200 minutes. A separate meta-analysis evaluating PNE plus exercise against exercise alone confirmed a clinically meaningful advantage of approximately 2 points on the 0 to 10 pain scale in the short term. A BMJ network meta-analysis incorporating 97 randomized controlled trials and 13,136 participants provided further convergent evidence, reporting a large treatment effect for pain education combined with physiotherapy, placing this combination among the most effective, non-surgical treatment approaches for chronic low back pain. These consistent findings across multiple high-quality meta-analyses establish PNE combined with active rehabilitation as a first-line intervention for chronic low back pain, with effect sizes that are clinically meaningful and that compare favorably with pharmacological alternatives. However, PNE delivered as a standalone intervention, without concurrent exercise or physical rehabilitation, doesn't yield significant improvements in pain intensity. This has important clinical implications. PNE should be thought of as a facilitating intervention that enhances the effectiveness of active rehabilitation rather than a sufficient treatment on its own. The mechanism by which PNE amplifies the benefits of exercise likely involves the reduction of fear avoidance beliefs, catastrophizing, and kinesiophobia that otherwise serve as barriers to meaningful engagement in physical activity. The effects of combined PNE and exercise on disability are equally strong. A cumulative PNE dose of 150 minutes combined with exercise exceeded the minimal clinically important difference for disability, with a mean improvement of 6.84 points on standardized disability scales. These disability outcomes are particularly clinically significant, as disability reduction is frequently a more meaningful outcome for patients than pain intensity reduction alone. PNE combined with exercise also shows significant effects on fear avoidance and catastrophizing, two of the most potent psychosocial predictors of chronic pain outcomes identified in Module 6. Meta-analytic data show a clinically meaningful reduction of nearly 8 points on the pain catastrophizing scale and a large reduction in kinesiophobia when PNE is combined with exercise. Mediation analyses have provided mechanistic insight into these effects, showing that reductions in kinesiophobia and central sensitization-related distress mediate improvements in disability and quality of life, while changes in catastrophizing and pain intensity don't serve as mediators. These findings suggest that PNE exerts its therapeutic effects primarily through modification of movement-related fear and central sensitization perceptions, rather than through direct modulation of catastrophizing cognitions, a distinction with direct implications for how clinicians should frame and deliver educational content. Pain reprocessing therapy, or PRT, represents an emerging psychological intervention that teaches patients to reappraise pain signals as non-dangerous brain-generated outputs rather than indicators of tissue damage. As discussed in Module 4, a landmark randomized controlled trial showed that 66% of PRT participants achieved pain-free or nearly pain-free status, with large effect sizes maintained at 1-year follow-up and measurable changes in pain processing circuits on functional MRI. Reattribution of pain to mind-brain processes rather than peripheral tissue damage-mediated pain reduction, providing direct evidence that changing the cognitive appraisal of pain can produce measurable neurobiological changes in pain processing circuits. The dose-response relationship for PNE has been quantified with unusual precision in the recent literature, giving clinicians actionable prescriptive guidance. The optimal cumulative dose for pain reduction is approximately 200 minutes when combined with exercise, while a cumulative dose of 150 minutes is sufficient to exceed the minimal clinically important difference for disability. Dose-response analyses have established specific thresholds for different outcomes. 100 minutes of cumulative PNE is sufficient to achieve the minimal clinically important difference for kinesiophobia, 200 minutes for anxiety, and 400 minutes for catastrophizing. These graduated dose requirements have important practical implications for treatment planning, as they suggest clinicians should tailor the total PNE dose to the specific outcome domains that are most clinically relevant for each individual patient. Delivery format influences both the magnitude and the nature of therapeutic effects. Individualized one-to-one oral sessions with reinforcement have been identified as the most effective format for improving pain and disability outcomes. Group-based PNE delivery, while less effective for pain reduction, shows a large and clinically meaningful effect on kinesiophobia, making it a viable and resource-efficient option when kinesiophobia is a primary treatment target. Digital and multimedia PNE formats have been shown to produce equivalent outcomes to face-to-face delivery for pain and catastrophizing, supporting the scalability of PNE through technology-assisted platforms. Session content analysis indicates that the number of target concepts addressed and the degree of focus on reconceptualization of pain and behavioral change are the strongest content-level predictors of pain reduction outcomes. The manner in which clinicians communicate pain science concepts profoundly influences patient engagement, therapeutic alliance, and treatment outcomes. Effective communication begins with validation, an explicit acknowledgement that the patient's pain is real, legitimate, and not being attributed to psychological weakness or fabrication. The International Association for the Study of Pain's definition of pain affirms that pain can exist without identifiable structural pathology, providing clinicians with a scientific basis for validating pain experiences that aren't explained by imaging or examination findings. The American Academy of Family Physicians recommends beginning by listening to and addressing patients' fears and concerns, with explicit reassurance that the clinical explanation doesn't attribute hypochondriasis. Qualitative research consistently identifies the therapeutic alliance as the single most important determinant of patient acceptance of PNE, which tells us the relational context in which educational content is delivered matters as much as the content itself. Evidence-based metaphors provide powerful tools for making complex neuroscience accessible. Central sensitization can be effectively communicated through analogies such as an overly sensitive car alarm that goes off when a leaf falls on it, or a volume knob turned up too high. The brain's role in pain generation can be illustrated through the metaphor of a fire alarm triggered by burnt toast rather than a house fire. The structure-pain disconnect can be normalized by comparing imaging changes to gray hair and wrinkles, or an old car with dents and scratches that still runs well. Educational material incorporating metaphor and narrative has been shown to significantly improve pain biology knowledge with a large effect and reduce catastrophizing in randomized controlled trial evidence, with effects maintained at 3 months. Neutral biopsychosocial explanations such as mind and body work together show the greatest patient resonance, while explanations that mention stress, distress, or cognitive bias receive lower acceptance. Common communication pitfalls include phrases such as, "it's just stress," or "it's all in your head," which are universally reported as invalidating. Abrupt reconceptualization of pain without first exploring the patient's existing beliefs leads to skepticism and resistance. Didactic, one-way delivery without interactive engagement is perceived as dismissive, while insufficient attention to the emotional dimension of the pain experience undermines therapeutic trust. Despite the strong evidence base for PNE, significant barriers to clinical implementation persist. Key barriers include biomedical pain beliefs among both patients and providers, lack of training and confidence among clinicians, time constraints in clinical settings, and system-level resource limitations. Process evaluation data reveal that only 44% of patients in a PNE-trained group reported that pain was discussed as a perceived threat, highlighting a substantial gap between the intended content of PNE and its actual delivery in routine practice. These implementation challenges suggest that training programs must move beyond didactic instruction in PNE content to include deliberate practice of communication skills, experiential learning, and strategies for integrating PNE within existing clinical workflows. Integrating motivational interviewing techniques with PNE has been proposed as a strategy for enhancing patient motivation and adherence, particularly among patients who are ambivalent about reconceptualizing their pain experience. International Delphi consensus recommendations emphasize the importance of assessing patient motivation, readiness to change, and expectations before initiating PNE. Tailoring educational content to patient profiles, and incorporating graded exposure and pacing as behavioral complements to cognitive education. Health literacy is an essential consideration in PNE delivery. Universal health literacy precautions, including avoidance of jargon, limiting key messages to 3 per visit, and employing the teach-back cycle, are recommended for all patients. Culturally sensitive PNE materials have been developed and validated for diverse populations, and thorough acceptability testing has shown 100% acceptability across all health literacy levels. Assessment tools for evaluating the effectiveness of PNE are increasingly refined. The concept of pain inventory for adults, or copy adult, is a 13-item instrument with good internal consistency and excellent test-retest reliability that directly measures patients' conceptual understanding of pain. The revised Neurophysiology of Pain questionnaire remains widely used as a measure of pain biology knowledge. Downstream psychosocial measures responsive to PNE include the Pain Catastrophizing Scale, Tampa Scale of Kinesiophobia, and Illness Perception Questionnaire, with improvements of 9% to 17% and moderate effects documented after blended learning PNE. Long-term evidence for PNE outcomes remains limited beyond 12 months. Meta-analytic data suggests small to moderate effects on pain at long-term follow-up, but effects on disability and psychological distress don't maintain statistical significance at long-term time points. These findings indicate that PNE may require periodic reinforcement or booster sessions to maintain its therapeutic benefits over time. Large-scale pragmatic trials currently in progress, including the IMPACT LBP trial with 1,800 participants and 24-month follow-up, are designed to evaluate PNE's impact on healthcare use and long-term outcomes, and their results will provide critical evidence for the sustainability and cost-effectiveness of PNE in routine clinical practice. With the foundational science established across modules 1 through 7, the following case studies integrate concepts from all preceding modules into realistic clinical scenarios that illustrate the complexity of low back pain assessment and management. Each case is designed to reinforce multiple learning objectives at the same time and to show the practical application of pain neuroscience principles in routine clinical decision-making. Case 1. The Weekend Warrior, Acute Low Back Pain, the Imaging Cascade, and Nocebo Effects. A 42-year-old male recreational athlete presents with acute low back pain of 3 days' duration following a deadlift injury during a weekend gym session. He reports moderate pain rated 6 out of 10, localized to the lumbar region with no radicular symptoms, no bowel or bladder changes, and no red flag features on examination. Concerned about a structural injury, he obtained a lumbar MRI through an urgent care clinic, which reveals a disc bulge at L4-L5, mild facet arthrosis, and an annular fissure. Findings the radiology report describes as degenerative disc disease with disc bulging. This case illustrates the clinical significance of understanding asymptomatic imaging prevalence data. For a 40-year-old adult, systematic review data show that disc bulges are present in approximately 50%, disc protrusions in 33%, annular fissures in 22%, and facet arthrosis in 25% to 50% of entirely asymptomatic individuals. Almost all individual MRI finding effect sizes are less than 1 unit on a 0 to 10 pain scale, indicating minimal clinical impact. The findings on this patient's MRI are statistically normative for his age and can't be assumed to represent the source of his acute symptoms. The language used in the radiology report, degenerative disc disease, carries significant nocebo potential. Research involving 1,375 participants has shown that pathoanatomical labels such as disc bulge and degeneration lead to significantly higher perceived need for imaging, increased perceived seriousness, reduced recovery expectations, and increased desire for surgical intervention compared to non-structural labels such as episode of back pain or lumbar sprain. The patient's catastrophizing response is a predictable consequence of receiving alarming diagnostic terminology without adequate clinical context. The natural history of this patient's condition strongly favors recovery. Community inception cohort data show that the median duration of an acute episode is approximately 5 days, with a cumulative probability of recovery of 70% before 1 week, 86.1% before 3 weeks, and 93.5% before 12 weeks. Current clinical practice guidelines are unanimous in recommending against routine imaging for nonspecific acute low back pain without red flags. An early MRI within 6 weeks has been associated with a 13-fold increase in the likelihood of surgery, greater opioid use, higher final pain scores, and 45% increased acute care costs. The clinician should reframe the imaging findings using neutral language, provide epidemiologic context by sharing age-matched asymptomatic prevalence data, offer reassurance regarding the favorable prognosis, and encourage continued physical activity. Case 2. The Desk Worker with Persistent Pain, Central Sensitization, and Pain Neuroscience Education. A 55-year-old male office worker presents with chronic low back pain of 4 years' duration that has been unresponsive to multiple interventions, including physical therapy, epidural injections, and a trial of duloxetine, a serotonin norepinephrine reuptake inhibitor used for centralized and neuropathic pain. His central sensitization inventory score is 52, above the 40-point threshold associated with central sensitization. His pain catastrophizing scale score is elevated at 34, and conditioned pain modulation testing reveals impaired descending inhibition. He's classified as high risk on the START back screening tool. This presentation is consistent with a predominantly nociplastic pain phenotype. Higher CSI scores are independently associated with increased risk of chronic low back pain, with each additional point slightly but reliably increasing that risk, and greater pain intensity and disability. In community physiatry clinic studies, 88% of patients with chronic back pain met criteria for primary nociplastic pain despite nearly universal imaging abnormalities. Pain catastrophizing has been identified as the psychological factor with the most consistent association with poor long-term outcomes, and the SBST high-risk classification identifies patients of whom 80% will experience persistent disabling pain at 6 months. Evidence-based management for this patient should center on combined PNE and exercise. Meta-analytic evidence shows that PNE combined with exercise produces a mean pain reduction of 2.61 points on a 0 to 10 scale at approximately 200 minutes of cumulative dosing, while 150 minutes exceeds the minimal clinically important difference for disability. Mediation analysis confirms that reductions in kinesiophobia and central sensitization related to stress, rather than changes in catastrophizing directly, mediate improvements in disability. For this patient's elevated catastrophizing, the dose-response literature indicates that approximately 400 minutes of cumulative PNE may be required to achieve the minimal clinically important difference for this specific outcome domain. Pain reprocessing therapy represents an additional option, with 66% of participants achieving pain-free or nearly pain-free status in randomized controlled trial evidence, accompanied by measurable reductions in pain-evoked neural activity. The reversibility of neuroplastic brain changes associated with chronic pain, including demonstrated recovery of cortical thickness in the DLPFC following successful treatment, provides a powerful therapeutic message for this patient. Case 3. The postmenopausal patient with complex comorbidities. A 62-year-old postmenopausal woman presents with chronic low back pain of 6 years duration, accompanied by insomnia, moderate depression, with a patient health questionnaire. 9 score of 14 on a 0 to 27 scale, where 10 to 14 indicates moderate severity, and obesity with a body mass index of 34, where 30 or above indicates obesity. She has undergone 3 lumbar MRI studies and 2 failed courses of epidural steroid injections. She reports feeling that her pain has been dismissed by prior clinicians and that she has been told, "There's nothing more we can do." This patient belongs to a precisely characterized high-risk subpopulation. Postmenopausal women carry a disease burden nearly twice that of age-matched men, attributed to estrogen decline, osteoporosis, and accelerated disc degeneration, with high body mass index contributing to 14.2% of low back pain-related disability-adjusted life years in this group. Sleep disturbance represents both a contributor to and consequence of her chronic pain. Baseline sleep problems increase chronic musculoskeletal pain risk by roughly 39% over the long term. Each standard deviation increase in sleep disturbance scores produces the largest increase in pain and disability among all modifiable risk factors, and poor sleep quality explains up to 45% of income inequities in pain. Depressive symptoms are associated with higher pain intensity, greater disability, and worse recovery in chronic low back pain cohorts, and the cumulative burden of multiple psychosocial exposures amplifies risk in a dose-response fashion. Women with chronic low back pain demonstrate sex-specific neuroplastic changes, including hippocampal shape deformation and greater involvement of sensoromotor and affective limbic circuits with unique neuroimmune pathways. Genetic heritability of chronic back pain is higher in females than males, with largely non-overlapping risk loci. Clinical communication with this patient must begin with validation. The recommendation to listen to and address patients' fears and concerns, explicitly stating that the explanation doesn't attribute hypochondriasis, is particularly relevant given her history of feeling dismissed. The therapeutic alliance has been identified as the single most important determinant of patient acceptance of pain neuroscience education. Universal health literacy precautions, limiting key messages to 3 per visit, and employing the teach-back cycle should guide educational delivery. Neutral biopsychosocial framing, evidence-based metaphors comparing imaging findings to gray hair and wrinkles, and direct acknowledgement of the legitimacy of her suffering provide the communicative foundation upon which PNE and multimodal rehabilitation can be built. Case 4. The young manual worker, red flags and differential diagnosis. A 34-year-old male construction worker presents with severe low back pain of 2 weeks duration, accompanied by night sweats, unintentional weight loss of 4 kilograms over the past month, and increasing pain that is not relieved by rest or position change. He reports no recent trauma. He has a family history of colorectal cancer, and his job involves heavy lifting and prolonged awkward postures. This presentation demands urgent evaluation for serious spinal pathology. The combination of unexplained weight loss, night sweats, and pain unresponsive to rest constitutes a cluster of red flags that substantially increases the probability of malignancy or infection. For suspected spinal malignancy, a history of cancer combined with clinical suspicion carries the highest diagnostic value, very strongly increasing the probability of malignancy beyond any other clinical feature or combination. Although this patient doesn't have a personal cancer history, the combination of constitutional symptoms, progressive pain, and family history of malignancy warrants imaging despite his young age. Spinal infection must also be considered. The classic triad of epidural abscess, focal pain, fever, and neurological deficit is present in fewer than 20% of patients at diagnosis. Useful clinical features for identifying spinal infection include saddle anesthesia, which is the strongest single indicator, followed by radicular pain and focal spine tenderness, each of which meaningfully increases the probability of infection. A clinical prediction rule combining clustered findings has achieved excellent diagnostic performance, with a sensitivity of 97% and specificity of 77%. Visceral and vascular mimics must be systematically excluded. Pyelonephritis presents with deep, aching, constant flank pain with fever and urinary symptoms, while nephrolithiasis produces acute colicky flank pain radiating to the groin with hematuria, in approximately 90% of cases. Abdominal aortic aneurysm produces steady, deep, gnawing pain not affected by movement, with the classic triad of pain, pulsatile mass, and hypotension present in only 1/3 of cases. If initial evaluation reveals progressive neurological symptoms, cauda equina syndrome must be considered. New-onset bladder dysfunction, bowel dysfunction, saddle anesthesia, bilateral sciatica, and lower limb motor weakness constitute the cardinal features. Post-void residual volume greater than 200 milliliters is associated with confirmed cauda equina syndrome in 43% of cases, while post-void residual below 200 milliliters with no objective neurological signs makes the diagnosis rare. This patient's occupational risk factors are also clinically relevant. Carrying heavy loads, working in difficult postures, and lack of workplace recognition independently predict chronic low back pain incidence. Meta-analytic data show that high workload is independently associated with increased risk of chronic low back pain, and having a manual occupation is independently associated with a 46% increased risk of following a persistent pain course. Should serious pathology be excluded, these occupational factors will require attention in long-term management planning. Emergent MRI without contrast is the appropriate diagnostic step for this patient, consistent with guideline recommendations for imaging when red flags for malignancy, infection, or progressive neurological deficit are present. Thank you for completing this course. We will now review the exam questions to solidify your understanding. Question 1. According to the Global Burden of Disease Study 2021, approximately how many individuals worldwide were affected by low back pain by 2021? The correct answer is C, 628 million. Rationale. According to the Global Burden of Disease Study 2021, the absolute number of prevalent cases had risen to 628.8 million by 2021, reflecting a 62.6% increase from 386.7 million in 1990. Option A, 386 million, is the 1990 figure. Option D, 843 million, is the projected 2050 figure. Question 2. Based on community inception cohort data, what is the cumulative probability of recovery from an acute low back pain episode before 6 weeks? The correct answer is A, approximately 91%. Rationale. A prospective community inception cohort study found a cumulative probability of recovery of 90.9% before 6 weeks. Option B, approximately 70%, represents recovery before 1 week, and option C, approximately 86%, represents recovery before 3 weeks. Question 3. Contemporary prospective cohort studies indicate that the rate of transition from acute to chronic low back pain is approximately what range? The correct answer is D, 25% to 45%. Rationale. While traditional estimates suggested that only 5% to 10% of acute episodes would transition to chronicity, contemporary prospective cohort studies show the true rate is considerably higher, with 25% to 45% of acute cases progressing to chronic low back pain. A landmark U.S. prospective cohort study documented an overall unadjusted transition rate of 32%. Option A reflects the outdated traditional estimate. Options B and C represent intermediate ranges not supported by the contemporary prospective data. Question 4. Which of the following best describes central sensitization in chronic low back pain? The correct answer is B, amplification of neural signaling within the central nervous system resulting in pain hypersensitivity disproportionate to peripheral input. Rationale. Central sensitization is defined in the course as the amplification of neural signaling within the central nervous system that results in pain hypersensitivity disproportionate to any identifiable peripheral nociceptive input. Option A describes peripheral sensitization. Option C describes neuropathic pain from nerve root compression. Option D describes a structural degenerative process, not a pain mechanism. Question 5. According to the International Association for the Study of Pain, which of the following is a required criterion for nociplastic pain? The correct answer is A. Chronic pain persisting for at least 3 months with a regional distribution not fully explained by nociceptive or neuropathic mechanisms. Rationale. The International Association for the Study of Pain. Clinical criteria for nociplastic pain require chronic pain persisting for at least 3 months, a regional pain distribution not fully explained by nociceptive or neuropathic mechanisms, clinical signs of pain hypersensitivity, and comorbid symptoms. Option B describes neuropathic pain criteria. Option C describes a structural pathological model inconsistent with nociplastic pain. Option D describes acute nociceptive pain with a normal healing trajectory. Question 6. Research on neuroplastic brain changes in chronic low back pain has demonstrated what? The correct answer is C. Successful treatment can lead to significant increases in cortical thickness in affected brain regions. Rationale. The course states that successful treatment can lead to significant increases in cortical thickness in the left dorsolateral prefrontal cortex and primary motor cortex at 6-month follow-up, with increased dorsolateral prefrontal cortex thickness correlating with reductions in both pain intensity and physical disability. These changes represent neuroplastic reorganization that is reversible with effective treatment, contradicting option A. Structural brain changes occur across chronic low back pain populations regardless of identifiable spinal pathology, contradicting option B. While these changes are not permanent, they do not resolve without targeted intervention, contradicting option D. Question 7. Which of the following findings is supported by dose-response meta-analytic evidence on pain neuroscience education? The correct answer is C. PNE combined with exercise produces clinically meaningful pain reduction at approximately 200 minutes of cumulative dosing. Rationale. The course states that pain neuroscience education combined with exercise produced a mean reduction of 2.61 points on a 0 to 10 pain scale, exceeding the minimal clinically important difference at a cumulative dose of approximately 200 minutes. Pain neuroscience education delivered as a standalone intervention does not yield significant improvements in pain intensity, eliminating option A. Mediation analyses showed reductions in kinesiophobia, not catastrophizing, mediate improvements, eliminating option B. Individualized one-to-one sessions are identified as the most effective format for pain and disability outcomes, eliminating option D. Question 8. According to the chronic low back pain literature, which psychological factor has the most consistent evidence of association with poor long-term outcomes? The correct answer is B. Pain catastrophizing. Rationale. The course explicitly states that pain catastrophizing has been identified as the single psychological factor with the most consistent evidence of association with poor long-term outcomes across the chronic low back pain literature. While depression, anxiety, and sleep disturbance are all significant risk factors, catastrophizing has the strongest and most consistent evidence base. Question 9. When screening for suspected spinal malignancy, which clinical feature carries the highest diagnostic value? The correct answer is A. A history of cancer combined with clinical suspicion. Rationale. The course states that for suspected spinal malignancy, a history of cancer is the most diagnostically valuable individual clinical feature, with specificity approaching 99%, and when combined with clinical suspicion, this pairing yields a very strong positive likelihood ratio. Other commonly cited red flags, including night pain, age greater than 50, failure to improve after 1 month, and unexplained weight loss, have limited diagnostic value in isolation. Question 10. According to systematic review data on asymptomatic adults, what is the approximate prevalence of disc bulges in individuals in their 50s? The correct answer is D, 60%. Rationale. The course states that disc bulges are present in approximately 30% of asymptomatic adults in their 20s, increasing progressively to 40% in the 30s, 50% in the 40s, 60% in the 50s, and exceeding 80% by the 8th decade. That concludes the exam review. Thank you for your engagement with this material, and we wish you the very best in applying these evidence-based principles in your clinical practice.